Hello and welcome to the Crux of Medtech. We go beyond the buzzwords, bringing you the insights from the innovators, investors, and leaders who are driving this life-saving space forward. Because I'm absolutely fascinated by the stories that people have to tell in medtech. As someone who works in this sector on a daily basis, I come across so many interesting people and so many interesting stories that I think the world deserves to know about. Welcome to the Crux of Medtech.
Hello and welcome to the Crux of Medtech. Now this is actually a super special episode. It's launching our new podcast, The Crux of Cardio, which will be hosted by our principal consultant and expert in the cardiovascular sector, Jordan. He'll do a quick intro in a second. But we've also got here Patrick from SynCardia and Jack and Rocky, who have very much been affected by this company. So we'll get into introductions in a minute. But first of all, Jordan, do a quick intro to yourself so the audience know who they're speaking to.
Cool. So hi everyone, I'm Jordan Bergin. I'm a principal consultant. I help build global teams to support fundraising for companies, in particular the cardiovascular and minimally invasive surgery space. So over the past 7 years, I've partnered with medtech innovators from early stage startups to global strategics, and we'd help them through every stage from R&D through to commercial scale up. And I'll be the new host for the Crux of Cardio.
Perfect. So diving into this, it'd be great, Jack and Rocky. So tell us a bit about who you guys are and how you've been exposed to the total artificial heart of SynCardia.
Sure. So I'm a congestive heart failure patient. I was diagnosed about around 2022 or so, and I've been living with that for a while, and kind of had a long journey of recovery from that particular disease that involved both the total artificial heart implantation for a time, and then most recently a heart transplant.
And I'm Rocky, Jack's wife and caregiver.
Cool. Yeah, I guess firstly as well, Jack, do you want to quickly give a bit of a background into yourself as well? I believe that you are also a clinician by trade.
Yeah. So I'm a clinically trained radiologist. So that definitely helped put highlight a new focus on my whole medical journey, being on the other side of things. Yeah.
Absolutely. As a clinician, you obviously knew more than most people would know about what was happening. How do you think that helped you cope? Do you think it made things easier or harder?
I think it was actually probably a double-edged sword. Certainly being able to speak the same language, so to speak, as the cardiologists, et cetera, that came in was helpful. I gotta say I was blissfully ignorant of a lot of cardiology before I went through this entire process. As a radiologist, a lot of the heart imaging is done by the cardiologists themselves. A lot of the hemodynamics and things like that kind of get passed over in our education because we're focusing on other things, at least after the medical school phase. So it was a very educational experience for me in that regard. Double-edged sword because I think, especially during some of the rockier times of my ICU stay, knowing exactly what was going on and the ramifications of, what my vitals were, what my numbers were, how much of which medications I was needing was always weighing pretty heavily on my mind, versus maybe if I had less knowledge of those things, that would have been a little more peaceful at times.
What was your first signs of heart failure, Jack? So how did you actually find out that you were going to actually need to be a patient?
Yeah, so like I said, I presented about 2022, and my first signs were just shortness of breath with exertion, and then eventually at rest. I thought it was a number of other things before I finally came into the hospital to get it checked out, and then on that initial visit, I was at a different hospital here in town. I was misdiagnosed with a pulmonary embolism for a little while, so that's kind of what we thought it was, which would have made a little bit more sense, but eventually they did do an echocardiogram and found out that I had an ejection fraction of 5 to 10%, which is pretty much the number doesn't get any lower than that. So that was very obviously the problem. And then from there did a myriad of workup and wasn't really able to find an exact preceding cause. We think it's probably some post-viral illness that I didn't really appreciate the initial virus of. But that's sort of how that presented in the first place. And again, that was in 2022. And then I more recently came into the hospital at very early 2025 when it had progressed. And that's when I sort of began my journey in the cardiac ICU and with the total heart, et cetera.
Just a quick one, Jack. being a clinician, what was the first thoughts going through your head when you heard the words total artificial heart?
Yeah, that's actually, it's a great question, because I had been exposed to this a little bit in training, which I'd done here in the Phoenix area. And, these devices, at least to some part, were, either created or initially worked on to a heavy degree, obviously down in Tucson, where SynCardia is located at the University of Arizona. And, I remember I was given a little bit of education on this in the radiology department here. I didn't work at a hospital that worked with them very frequently, but we were at least aware. But the the presentation material they'd used, it wasn't SynCardia specifically. It was very, very old. They were showing me pictures from the very first of these inventions, which I think were from back the 60s or 70s. A very different piece of technology than it is today. So when I was first, told about that possibility, I had a very different idea in my mind from what ultimately ended up happening.
Yeah, I don't think I'd be one of the person Googling those images from 40, 50 years ago. I think that might scare me off a little bit. What was the moment like when it hit you that this device is, essentially going to become your heartbeat?
So we were, that was sort of it was fairly progressed along in my ICU course when, we were making the final decisions on, mechanical circulatory support. Now, thankfully, the team at Banner is great in exposing you to this idea early. As soon as you're put on the transplant list or being looked at for a transplant evaluation, they have someone that's very well versed in the technology on their MCS team come in, show you the LVAD, show you the total artificial heart, just so you're at least familiar with the devices. Now, I'll be honest, when they first came in to talk to me about that, we hadn't even completely decided to go with a heart transplant yet. We thought that maybe we could get a couple more years out of my native heart. So I was paying attention, but I was thinking, this is something I'm going to need. But obviously after 2 or 3 months in the ICU, your perspective on things changes and you realize you are going to need, some additional help. And in my particular case, I definitely needed some help bridging to get it to be a adequate transplant candidate. So, at that point, this was a couple months later, I had a frank discussion with the surgeons and the cardiologists there, and the total artificial heart was definitely the way to go. They explained to me, my right ventricular function wasn't adequate enough for quote unquote just an LVAD, so the total artificial heart would probably be the way to go. And after we made that decision, we were gung ho and full bore ahead to get the procedure and get all the support that I needed to be able to take care of myself, both with or without the device.
And Rocky, how was all of this for you? So sitting alongside someone who's going through not just a total artificial heart, but now also a heart transplant, like how does that kind of go for you as the partner of someone going through this?
Yeah, so it is very emotionally demanding. And as I mentioned, it's an emotional roller coaster throughout the whole thing. There were scary moments, and like when they presented the, total artificial heart as an option for Jack to bridge him over to getting a transplant, that was foreign to me and very scary because I didn't know anything about it, leading up to that point. So, I've learned a lot throughout the process, and I'm so grateful for where we're at now. But leading up to today, it was very emotionally demanding.
Sure. And without the total artificial heart, what would have happened? Like, what would have been the options, and would you be sat here today?
Yeah, so I really don't think so, because like I said, I was in the cardiac ICU for 2 or 3 months, and I went through, about a month in, we decided, okay, let's go through a transplant evaluation. Got evaluated. That takes a couple weeks, but, nothing came up as a red flag to keep me off the transplant list. But over that time, I was getting progressively more sick. They were having a hard time keeping my ejection fraction up, even on all the IV inotropes and things like that. And, so eventually, I'd like to think about my hospital stay in terms of the stages of the transplant waiting list that I was on. So, stage 3, you go in, you're on some IV medications that try to jumpstart your heart in terms of its contractility. I went through that, and I was still having some end organ dysfunction just from the lack of blood flow throughout my entire body. So at that point, they went in and put an Impella device, temporary percutaneous MCS, or mechanical circulatory support, and that helped for a little while. But at that point, I'd actually, after a couple weeks on that, again, progressively got more sick. My heart was super dilated at this time. And it was actually Valentine's Day of this last year that I went into cardiac arrest and ventricular fibrillation. Needed, 4 pads and 6 or 7 shocks in order to get spontaneous circulation back. So, and then I woke up and I was on ECMO, which is really kind of the end of the line in terms of, supporting your heart. You have these huge cannulas. For me, it was a little bit different. It was VA ECMO. So they went in through through the femoral site, and it was somewhat of a unique circumstances because most of the patients on VA ECMO in the hospital are intubated the entire time, but I was otherwise, I guess, well enough that I could be awake. So I was awake, but had to lay down for, I think it was 22 or 23 days. They ultimately had me on that. And, at that point, again, I'm at the highest stage of the waiting list. So I'm a status 1, basically, territory 5 or whatever, how it is they break up the United States into different territories for your heart transplants. And so in my territory, like basically the next heart that comes up should have been mine. But, over those 2 to 3 weeks on ECMO, I would just occasionally throw fevers, have high white counts, things like that made them think that I may have been infected. They never really found anything, but it was enough to get me on and off the transplant list. They take me off, they put me back on. So it was tough because I was in a position where, I was getting very, very sick. And at this point, I needed to be intubated, and the details are a little hazy, but, I was just getting very sick, and without the total artificial heart in order to bridge me until I could get better, there really wouldn't have been too many other options. So again, we're eternally grateful for that.
Yeah.
In terms of, how those conversations went and what happened exactly while I was intubated, I'm not entirely sure, but I'm just happy that I woke up at the other side of it. So
I could fill in any of those gaps.
I was just about to ask you that, Rocky. I was going to say Jack might not have known what was happening, but I'm sure you had some feelings and thoughts at that time. Bad timing, by the way, Valentine's Day, Jack. But Rocky, if you'd like to tell us about that, how you was feeling throughout that whole process.
Yeah, it was quite overwhelming because, when they intubated him and, he was unconscious, I had to help with a lot of the decisions, and there was a lot of uncertainty because he was spiking these unexplainable fevers. And as he mentioned, they had to take him off the transplant list. They weren't able to operate on him without knowing what was causing these fevers. So, as we went on every day, these tests were coming back negative, just no idea what was causing these fevers. So, 2 weeks into that, we kept meeting with the medical team, and, they were trying to, their main goal was to figure out what is causing these fevers and how can we stop the fevers without just masking them with Tylenol, because they didn't want him to go into septic shock when he went into surgery. So, they finally, 2 weeks in, came in and they had told us, let me back up. Before he went under, they presented the option of the total artificial heart, which Jack agreed to. But like I said, he went under because his oxygen levels were so low. And so, leading up to that, Jack didn't know if he was going to wake up with a total artificial heart or if he was going to wake up in hospice. And those were the options at this point. So anyway, 2 weeks in, the surgeon comes in and he says, I'm going to take a shot. We still had no idea what was causing these fevers. And he said, this is his last hope. And I'm going to go ahead and take a shot because he was just getting progressively sicker even while he was intubated and on life support. So, So yeah, we're so thankful that that surgeon decided to take the risk. It was a huge risk, and it turned out to be a major success. But yeah, it was very scary throughout that whole period of time, and not being able to talk to Jack or, get advice from him, because he's usually the one that guides me on, what to do or what decision, help me come to a decision. So that was extremely difficult. And, as I mentioned, the chance that he could be going to hospice was very daunting throughout that time.
Wow. And I mean, that's incredibly impactful for you guys. But with, and Patrick, we will do a proper introduction to you in a minute. But this isn't just a singular experience for Jack and Rocky. This is happening to a number of patients. And is this quite a common occurrence to have this kind of story with the artificial hearts you guys provide?
Yes, Henry. I think we have to date, we've treated over 2,100 patients with a SynCardia total artificial heart. And obviously I, have not met with everybody, but I've met with a good dozen or so patients. I've heard stories. And I think the experience here by Jack, and also in some cases I've also been able to understand family is very similar, right? I think it is I think at the bottom, it is a challenging experience for the patients. It's a challenging experience for loved ones. I can only say we're on behalf of SynCardia, of everybody at SynCardia, 70 people plus, right, who manufacture these hearts and make sure that they're functioning and operational. I'm extremely pleased and happy that we could help Jack and also Rocky. I mean, it makes a huge difference here. And also all the other patients, right? It's obviously also dependent on the medical team at the hospital where they are. We work with a number of transplant centers. Jack was, in a sense, as you pointed out, Jack, super lucky, right? You were probably at the best center you can be in the United States, at Banner Hospital in Phoenix, to receive a SynCardia total artificial heart. A super experienced team. I think Dr. Arabia and his team, they've, have decades of experience with the device. So you were in the best possible situation you could be given the circumstances, I think. And we've met a bunch of times, right? I'm super happy to be able to talk to you. And I think, you've also had the opportunity to meet with staff here. And I can tell you it makes a huge difference to everybody to see, to the guys in shipping, to the guys in manufacturing, this is the life we saved. And I think that's a huge motivation for all of us here at SynCardia to do what we're doing.
Thank you very much for that, Patrick. I actually wanted to zoom back out to Jack for a moment, because it's a question that's been playing on my mind quite a bit before this podcast. So, it's a huge procedure and device. And how long did it take you before you stopped being aware of having a total artificial heart and started living again?
Yeah, so I'd say after I got the total artificial heart, I was in the hospital for about 6 more weeks while I recovered from the surgery, did a little physical therapy and things to get back up on my feet. And after that, the team is really good about having you adhere to a cardiac rehabilitation program, just like a transplant patient, or just like an LVAD patient, or just like a congestive heart failure patient that's on medications. They take you into a gym, basically. They put you wired up to a telemetry machine, check your blood pressures occasionally, and make sure that you're sort of stable while doing more activity than you used to. And I would say, all told, from when I got the device, probably about 2 months out, where I was feeling like I was good enough to be able to get up, go around, and do things. A big step in that is 2 to 3 months out, when you're able to get off of your sternal precautions. After this heart surgery, you have this big sternotomy, and you're not really supposed to use your upper body too much. But then after you get off of those, you're able to wear the device around similarly to a backpack. That's really when I regained most of my activities of daily living, be able to be more self-sufficient and just doing things around the house. and it's just like normal, except carrying a little backpack around. So it wasn't too long, and I'd say it's about the same recovery. I have the benefit of comparison. It's about the same recovery as after my heart transplant itself. So between the 2 to 3 month range is about when you're able to get up and do things that you're used to doing again.
And then one more question for me. You kind of alluded to it earlier, and it was you mentioned that when you was in hospital and you was looking at the the ECG and everything like that, and it sort of made you spiral out in the mental game. What's harder when it comes to a total artificial heart transplant? Is it the mental side of it, or is it the physiological side of it?
For me, I think it was the physiological side of it. I had such a great support system here with my wife, and we had some family in town as well. But it just being able to have the support with me would really helped deal with a lot of the aspects of not just the total artificial heart, but going through this whole worsening disease process. From a physical standpoint, it takes a little getting used to, because you need to be always aware of the safety protocols around it. Little things that you wouldn't think about, but we needed to make sure we had emergency phone numbers to our local fire department in case our power went out. It's something that you need to continuously make sure you have a power source for. So, things like that, things like bringing a backup when you go to the grocery store and things of that nature, where at first it takes a little getting used to, just remembering to check all these boxes. But after you have that and you're sort of in the habit of it, it's really kind of comes as second nature. So.
Amazing. Well, I think with Jack and Rocky, thank you so much for joining us. We're going to intro Patrick in a second and get the SynCardia take on this, but thank you so much for joining us so far.
Thanks for having us. Yeah.
I'm interrupting this episode to bring you a word from our sponsors, TTP. TTP is a leader in complex medical technology development with deep scientific and engineering expertise. They support ambitious medtech companies in solving high-risk, high-complexity challenges where there's no margin for error. Whether you're tackling uncharted technical territory or racing to bring a product to market, TTP provide clarity and direction. By de-risking innovation and ensuring seamless alignment with regulatory and manufacturing demands, TTP help you move forward with speed and confidence. To find out more, check out the show notes. So that was a super impactful story from both Jack and Rocky there. So really, really interesting to hear that. But yeah, Patrick, you are the CEO of SynCardia. So it would be really great to understand how you got into the medical technology industry and get your story of why you stayed here, really.
Yeah, so it's probably a little bit of an unusual story how I got into this. Originally, actually, I studied at Harvard Medical School and MIT, but then decided to leave medicine and science. My intent was to become a medical researcher, but I left to become a management consultant with one of the big five strategy consulting firms, and then Big Four, and then went onto Wall Street, where I worked on the buy side and sell side, all kind of leveraging my science and clinical backgrounds to help mostly healthcare companies, and was a portfolio manager, was an investment banker, and in that role I got thrown into actually received an offer to join an immunotherapy company as their CEO. That was a startup. They were based out of Israel. And so I did that for a while, moved on back into financial advisory world, again, focused on mostly biopharma at that point. And one sunny day, I kind of sort of came across the medtech sector, which I always smiled mildly on because of, medtech, right? I was all into the cool biotech stuff and gene therapy and right? And that seemed sort of a little bit medieval. But here I am, right? I joined, I was working with several medtech companies, including vagal nerve stimulation, some combination products, and ended up in the cardiovascular space working for a company called Occlutech, became the chief operating officer. Occlutech develops devices for structural heart repair. So ASD occluders, PFO occluders they also have a heart failure device, a shunt device. And so that's really where I got into the cardiovascular class 3 medtech devices, and moved on to another company that was actually owned by Occlutech Procor, developing a heart failure device, and then moved on to a company called SynCardia, developing a minimally invasive left ventricular support device. And from there, and during that period, I actually got exposed to total artificial hearts. Number one, with this minimally invasive left ventricular support device. And I was also on the board of Scandinavian Real Heart, which is a European-based total artificial heart company. And one sunny day, I got a call from HR consultant telling me that SynCardia is looking for a CEO, and I looked at the opportunity, and I knew about SynCardia at that point since I was at the board of Real Heart, and always was very impressed with the technology compared to what's out there, with the performance, and obviously also with the mission of really providing a therapeutic option to patients who would otherwise effectively die, right, in hospice. And so this was very compelling, and I guess I made the decision here to join SynCardia in 2003 in the middle of the year. And it's been a fantastic journey since then. It's been a lot of hard work, but I think together with my Chief Operating Officer, Matt Schuster, and my CFO, Bernard, who we all joined sort of in 23, we've really managed to build a fantastic organization. We have a dynamic team here. We've heavily focused now also on innovation, research, and development. We obviously continue focusing on the growing of our market here in the US. And we, it's been a fantastic journey. It's been tough, right? It's never easy at these companies. I think total artificial hearts, you cannot underestimate the complexity from not only, obviously you just heard from the patients, the involvement from both physical as well as emotionally, what patients go through, but also from our side, right? It's a huge enterprise to, keep a total artificial heart on the market, to make sure it meets all safety requirements, it performs, and also to continuously, progressively innovate, right? And one of the next big steps that we're undertaking here is really removing the need for having these external drivers that Jack was talking about. He needs to carry in a backpack. So we're now working on a fully implantable version of the heart, and that's the focus of the operation.
Sounds really good. And one of the things you mentioned was the technology is why you joined the business. You were impressed by the technology. What was it about this technology that's unique or different? Why this tech?
Well, I think the biggest, first of all, total artificial hearts, I think that's sort of the landing on the Mars for cardiovascular medtech, right? There's nothing harder, right? As Jack alluded to, this technology, the foundation for total artificial hearts was sort of laid back in the 60s, right? Our device is really the evolution of 30 plus years more, even more, of research and development, right? The first version of the SynCardia total artificial heart was approved in 2004. And since then, we are the device with the most clinical experience, right? Well over 750 years of patient experience based on these 2,100 implants. And that's really something that is quite compelling, right? The other part of it was, the implant is extremely simple in terms of the number of mechanical parts, how it works. It relies much on the body to regulate its pumping, based on the Frank-Starling syndrome and what we call partial fill, full eject. So we kind of need to set the heart rate for a patient, to determine cardiac output. We rely on the body auto-regulating, the pumping of the heart and the, cardiac output, if you will. So it's a really simple device, right? It's sort of KISS, keep it simple, stupid. And that adds, is a great platform. There's other devices out there. I think they're super impressive. But I think the simplicity of this device and the potential to convert this into a fully implantable product without having to do much change to it, basically just removing the external pneumatic system and replacing it with a mechanical pumping system. Those two things combined were a compelling argument for me to join the team here at SynCardia and start this journey.
Brilliant. You compared it to the moon landing or landing on Mars, which is absolutely right. What's the biggest challenge in bringing this innovation to more patients?
Awareness is probably number one, right? As you heard from Rocky, she had never heard of a total artificial heart. Fair enough. She's a healthy young woman, right? Probably not the top thing on the agenda to learn about total artificial hearts. But as as I've learned here joining SynCardia, it is there, there's a lack of awareness amongst healthcare providers that this device exists. In many cases, if there's awareness, the individuals are not completely informed about the benefits of the device, of the SynCardia Total Artificial Heart, when to use it, where to use it. And so these are really the biggest challenges, right? The history of SynCardia also, doesn't help, if you will. The company has been around, has ups and downs, and I think I still come across physicians and healthcare practitioners who are surprised. Oh, you're still around. I thought you all went bust in 2019, 2020. And so that hasn't really helped, right? But I think right now, and to some extent, so right now we're really focusing on bringing, creating more awareness, increasing the awareness of healthcare teams, of cardiovascular teams at the centers we're working at about the device. And I think that is working. They recognize that this is a valuable therapy. It's not for everyone, obviously. It's like frontline therapy. But there's definitely a right patient for the device. And so another point Rocky made in terms of the treatments he went through, right? He said he was on Impella, he was on, and then he was on ECMO, and he gradually worsened. And at one point, he also mentioned end organ failure that was imminent. So these are all points that, we're trying to sort of educate the caregiver healthcare practitioners that, look, again, it's not for every patient, but in some patients like Rocky, I think Rocky might have done better if he would have received the SynCardia Total Artificial Heart earlier. And so his recovery time would have been faster. And the good thing is patients can get discharged, right? The Freedom Driver allows you, as Rocky said, to move around. And so understanding all these features of the SynCardia heart and communicating that effectively to physicians. It's also once a cardiac team understands what the armamentum of devices they have access to, I think, and we're in there for the right patients, we also make a point of being there to support the caregivers. So we invest a lot of time upfront educating, training, not only the cardiologist, the cardiothoracic surgeon, but very importantly, the support team, the VAD team, the ICU team, because those are the folks who at the end of the day need to deal with the whole setup, right? Including the patient family, and also provide, post procedural support. So there's a lot of things we're doing. But I guess to sum it up, number one is really, educate healthcare practitioner on the utility and on the performance of the heart. And especially sort of the younger fellows that come in. Many of the sort of older generation cardiothoracic surgeons, they know the device. Many of them think we're no longer around. But it's important that the younger generations understands that this device exists, its benefits, and also what I call debunking data, right? There's a lot of information around. Some of it is sort of, urban myth type of thing. And really, we're making also a big effort here now, making sure that everybody really fully understands the clinical data that is out there, the benefits and the challenges that you have with a total artificial heart.
Brilliant. One thing that you alluded to, Patrick, that I wanted to dive a little bit deeper on. What makes patient selection for total artificial heart so complex, and compare it to, LVADs and bivads? What makes this so different?
Yeah, let me start with the end. I think you cannot compare a total artificial heart with an LVAD, right? And an LVAD is a left ventricular assist device. I think one analogy I like to use is sort of the choice is you're rebuilding the foundation, which is a total artificial heart, or you're supporting the wall of a building, which is an LVAD. So it's a very different thing, right? In one case, you really make the decision to replace a failing or failed human heart. In the other one, you support it. There are also specific patients that, where I believe a total artificial heart is an obvious choice, right? You can, for example, eliminate the risk of right heart failure in many of these patients with advanced stage heart failure. You have a number of congenital and cardiomyopathies, congenital diseases, defects and myopathies where the total artificial heart is a no-brainer. And I think that the choice is really, I think part of it is really, as I mentioned earlier, driven. Are you aware of the utility of the benefits, you, the healthcare professional, of a total artificial heart, right? And also taking the patient's journey into consideration, right? Do you want to put somebody for 10 days, 15 days, 20 days on an impeller, then graduate to ECMO? And so it's a sequence of things that, in retrospect, you might have said, if I would have gone in with a total artificial heart a bit earlier, the patient might have done better. So patient selection remains complex. It's not a straightforward algorithm. We clearly have certain metrics that we use that have been developed over time. And we, SynCardia here, we are working on developing better algorithms using a number of available technologies that are out there today, really analyzing historical patient data outcomes and focusing on how do we make the decision-making process for the clinical team easier from a clinical point of view. There's still, you will have the psychological factor in there, right? You got to go in there and take somebody's heart out. Not so much a problem for a cardiothoracic surgeon if he's got a transplant, a donor heart next to him, right? But it's probably a little bit of a different decision-making process. If there's a question mark between the donor heart or where's my donor heart coming from? It's also a big decision for the family, right? They're involved in many cases in that decision-making process, probably in most cases. The patient probably less so, because the patient will be in a position where they're pretty much, in the hands of their loved ones in terms of decision making. And so to this end, we're actually working with patients in a group called Unique Beating Hearts. That's a non-profit patient support group for SynCardia total artificial heart patients. And we work with them to kind of walk a family as they go through the process of making that decision. What happened to me, right? What will happen to you? Sort of to demystify or explain the process, what's happening. That's been very helpful. So it's a complex set of factors. It's clinical, decision making. It's psychological to some extent, and but lots of it is really outcomes driven, I think, and that's what we're trying to promote. Like, look at the clinical outcome, and we're collating data that we'll talk about soon, showing that we actually have pretty good outcomes longer term. And so those are sort of the biggest factors, I would say.
Got you. And is there any kind of area or grey area where patients who could benefit from a total artificial heart aren't currently getting it under current regulation or indications?
So I think right now, there's always grey areas. We probably have 2-3 times a month cases that come to us, and we kind of go to the evaluation, and then the patient, for one reason or the other, doesn't make it, right? And we drop it. And one reason or the other, they're too sick. And that's one of the gray areas, to really go to the center and said, you have it, don't wait, right? You use it earlier. So that's one thing.
How does that evaluation process go? Is that you guys at SynCardia making that evaluation? Is it the health? Who makes that decision? I
mean, these decisions are made typically by a sort of, I call them a cardiac care team. And in many hospitals, not all, but in the majority of centers we're working with, this is sort of a group, 10, 15 people, right? That includes obviously a cardiothoracic surgeon, a heart failure specialist, and then the nursing, the ICU team, the MCS team, and in many cases, also, in several cases, hospital administration. In terms of cost, right? This is always a question. And also, other support functions. So it's a group discussion, if you will. At the end, so typically the process, or in some hospital, the process will go, this team will meet, discuss the patient case, and then kind of move forward and say, this is the therapy we're going with, or that is the therapy we're going with. So that's why I'm saying it's really important for us to be in the front of everybody's mind, that we exist, right? You have the alternative of calling SynCardia. They can show up here with a total artificial heart. So that's kind of the group that makes the decision, right?
I like that. You sort of talked about looking forward there, and that goes into my next question, really. Like, where is this technology heading? People don't realize how old this technology is and how long it's been around. So what's going to excite them about the future of a total artificial heart?
Yeah. So you say one thing, how old the technology is, I would call it established. Again, it is not brand new. I get that. And I've always kind of been working with devices that are sort of at the bleeding edge, but the edge of innovation. And from that point of view, it's old. But the experience this device has is unparalleled, right, for any total artificial heart. And so that's a huge advantage. That said, clearly, I think our mission here is really to transform heart transplantation, right? Or to treatment of advanced stage heart failure. And that includes obviously providing access to the current version of the SynCardia total artificial heart that is driven by a pneumatic system, which by nature has to be external. I don't think it's possible to design a pneumatic system that's small enough so it becomes fully implantable. So that's the goal here is really to, again, along with the mission, develop a device, a fully implantable version that ultimately can serve as an alternative to heart transplantation. And so from a device development point of view, that's done by, as I mentioned earlier, eliminating the need for a pneumatic driver system. And that means you can now internalize it. And we're working with, we have a series of prototypes in development. We call this the Emperor devices. These are all devices that have various configuration of internal motors that are basically attached directly to the implant. And we're using the exact implant as we're using so far in patients. We're just cutting off the pipes, if you will, that lead to the pneumatic driver and use these motors to effect the moving of the membranes, the pumping of the heart. And so that's really the way forward in my mind, right? The device, number one, it'll be fully implantable, which means it's much better patient comfort. Fully implantable also implies that our mission of developing a fully implantable device that serves as an alternative to heart transplantation implies that we're a long-term device. We know that our current version of the heart can be used for long-term. Right now, it is not approved for long-term. Right now, we're approved as a bridge to transplantation. But we have data to support long-term use, and we're working with the FDA here and other regulatory authorities to expand our label, our use. But in the future, again, the fully implantable one, if that is usable as a long-term device to serve as an alternative to a heart transplant, it's probably going to last somewhere around 10 years, right? That will take some time to get there, but I think sort of the initial bar of 2 years plus 5 years is very achievable. Now, if you have a device that is fully implantable, doesn't need pneumatic drivers, that will improve a lot of the economics from a company point of view. You have less equipment, less devices to maintain. There's only an implant, right? And that allows you probably to access markets to give help, to provide this therapy, this device to markets that you currently wouldn't want to access, simply probably for the harsh commercial reality, right? We're working here in the United States. We're working in Europe. We will be going back into Europe in the future. But you have huge markets outside these two regions so these two regions both have heart transplant programs. In the world, you have probably somewhere 8,000 plus heart transplants done in total. Most of these heart transplants are done between the United States and Europe. So you have the whole rest of the world, China, the Middle East, Asia, the Middle East, Latin America, all these regions, who, for various reasons, do not do heart transplants. There's religious reasons, there's ethical reasons, there's no established programs, all kinds of reasons. But that's millions of patients. All of these regions have patients with end-stage biventricular heart failure. We're all dying from the same reasons, right? And I think having a device that's fully implantable would allow us to really provide care to many, many more patients out there than we currently can, and anybody currently can.
Another quick interruption to tell you about our sponsors, KUKA. KUKA is a global leader in robotics with over 25 years of experience partnering with medtech companies on their journey to market. Their reputation is built on robust technology, reliability, and long-term collaboration. More than a supplier, KUKA provides trusted support throughout the product lifecycle, from development to integration and beyond. For companies exploring robotic solutions, the KUKA LBR Med offers a ready-to-integrate, state-of-the-art option that meets the highest medical standards, without the need to build from scratch. If you want to find out more, then head to the show notes and follow the link to KUKA's website.
One of the things that plays on my mind a little bit is the cardiovascular is huge in terms of, indications, procedures, company volume, etc. There's not a huge amount of total artificial heart companies. Do you think this is because of the technological difficulties or market perception, fundraising efforts? It'd be good to get your take on that.
This is a really good question. I also have sleepless nights about the answer.
$1 million question.
I think the primary, I'm convinced there is a need and a spot for a total artificial heart, right? I'm also convinced that we need to continue, and that's what we're doing with the Emperor program at SynCardia. We need to continue to improve whatever technology we have right now in that space. Now, we have the benefit on standing on the shoulders of 20 plus years of experience with the current version of probably 40, 30 years plus of development in this device. And I think, as I said, it's like, it resulted in a very simple device. Now, there's other companies. There's a company called Bivacor out, right? They're in early feasibility studies with their product. It's a very different device from ours. It's more a pump-based device, so centrifugal pump plus an impeller. Then there's Carmat out there, which is it's an implantable pump. It's a beautiful, very complex device, lots of parts. And there's obviously Scandinavian Real Heart I was on the board on, which is also a good device in development. So there's at least 4 companies in this world that are, active in this space. I know there's quite a few others that are sort of developing these devices. And I think it is just very hard, right? You need the scrutiny, the regulatory scrutiny, the engineering challenges that you face, and the clinical results that you need to generate in order to convince, yourself and the world that this is a viable program. It's not a small feat, right? This is not developing a valve. This is not a stent. This is not, I don't know, again, I've been in this space, and I think this is probably the most complex thing you can imagine developing for a human body, right?
Can an artificial heart ever fully replace an actual human heart? So we've talked about this being a kind of end-of-life technology, but is there a world where the artificial heart takes over from needing a transplant?
I think so. And I think it's kind of very simple, right? I think if you can develop an implant that's durable enough. Okay, so let's go take a step back. Most patients who do receive a heart transplant, their life expectancy is somewhere up to around 10 years, right? And given, that's it. And plus minus. And so based on that, I need a device that I can implant that will run in your chest for 10 years, right? Or I have means to, if the need is to service it, right? But I can't really think about how that will work at this point. But I think, and we're ideally positioned, right? We have durability data and this is benchtop durability of the implant that is exceeding 10 years. So we know the implant non-stop pumping works for 10 years plus. And I'm very much oversimplifying here, right? But so the only thing we have to do is find a motor that lasts for 10 years inside of a human body. And there's a lot of technology out there. There's, maglev type technology that we can leverage. And so I do believe we can do that, right? The third part of it is battery life. You obviously need the juice to run that thing. You know, with the systems that we're looking at now, we can get to levels of energy consumption that parallel the human heart. And that with the battery technology for sure allows you to have an external battery that will last you for potentially up to 24 hours before you need to change it. And it's not a giant battery either. And so I think those are the minimum requirements, right? A 12 plus hour battery life, durability of the motor, in our case, and the implant. Again, I do believe that our durability data is compelling. So we have all the elements. So yes, I do believe we can make an alternative, ultimately to heart transplant, and a device that can be an alternative to heart transplantation. I totally think so. I wouldn't be sitting here if I wouldn't believe that. And the next step, obviously, having implantable fully with the battery and everything, right? That will be a little bit down the line, but yeah, it will happen.
How's the patient feedback been? Has it been, directly influencing the, design and clinical protocols for the next versions of TAH?
Yeah, so we're working. We're working. We're showing the prototypes we have. We're working with physicians. We're collecting input. We continuously have cardiothoracic surgeons to come here to SynCardia from across the United States. We show them our device. We listen to their input. We are, right now we have a number of prototypes, as I said, sort of different versions of the Emperor that we're testing. Animal studies are ongoing, right? We've announced that we will do that, so it's no secret. We have, a number of surgeons involved in these studies, and obviously, I've when I was with Occlutech and other companies, the most important thing was always show whatever prototype you have to the user, let them play with it, and collect as much comments input as you can. And I'm following the exact same approach here. Not only working with one or two, we're trying to get as much input as we can from the end user, the cardiothoracic surgeons, probably not the real end user, but the implanter.
Awesome stuff. So Patrick, from my side, that was a fascinating conversation to learn about. Is there anything you want to leave with the audience with, anything you want them to know about SynCardia or the work you guys are doing we haven't discussed yet?
No, I think we covered a lot of ground, right? I think, thank you for the opportunity. I think, I cannot say enough that, while we're running a business here and we're trying, obviously, to grow as a company, a huge motivation here is really for us, stories like Jack's, as we just saw earlier. And that's, it's a game changer, right? You can go to sleep at night and say, no matter where you are at SynCardia, right? I just saved a life. And that's a huge thing, right? I cannot think of many jobs where you have that dramatic of an impact on humans' life, other than being a surgeon or something like that, at least in the device industry. So that's a huge motivation for us. And I think, look at SynCardia as we're focused on really, as I said, developing an alternative to heart transplantation. And really, we're not the old SynCardia anymore. We're very aggressively focusing on innovation. Learn about us. Look at our website if you're interested. We're happy to talk to anybody who wants to learn more. And we have lots of clinical specialists and other people that would love to tell you about the SynCardia Total Artificial Heart.
Awesome. Thank you so much.
Thank you. Pleasure to being on Crux and on this podcast.
Thank you so much for joining me on the Crux of Medtech podcast. If you're not already doing so, please go ahead and subscribe on YouTube or follow the podcast on Spotify or wherever you get your podcasts. This podcast is proudly brought to you by Crux. Crux is a medtech search firm which places pioneers in transformative roles to help us live longer, healthier lives. We do 3 things for companies. We help hire world-class executive talent. We help companies raise investment from Series A to Series C and execute upon M&A. And we also are building a community of medtech leaders to facilitate peer-to-peer learning and accelerate the companies to help them go faster. If you're interested in any of those 3 things, please reach out to me on LinkedIn or follow the link in the show notes to find out more. Thank you.